And where is that? So my name is Sue Grinnell, and I am the director of the Population Health Innovation Lab, lovingly referred to as Phil. And we are housed at the Public Health Institute. And Phil is focused on the success of accountable communities of or for health, and also health-focused multi-sector collaboratives. And some of the ways that we do that are through research to practice, as well as facilitating systems change with multi-sector collaboratives. We intentionally seek opportunities, excuse me, to bring those that are stewarding the work of collaboratives to come together in dialogue, learning, and resource sharing. Before we dive in today, I wanted to just take a moment to do a land acknowledgement. If you could go back to the other slide, Catherine. My place of residence is Olympia, Washington, and it is on the traditional territories and ancestral homelands of the Nisqually, the Coast Salish, Cowlitz, and Chehalis nations. And we acknowledge the painful history of the genocide and the forced removal from this territory, and we pay our respect to the diverse indigenous people that are still connected to this land. And we give thanks to all of the tribal nations and the ancestors of this place. And we're putting a link into the chat that's a resource that's on the slide as well. And it's very handy, and you can actually put your location in and it will give you the tribes if you're not familiar with those, as well as information on land acknowledgement. So we welcome you here today, and this discussion is in follow-up to a discussion that was held on August 24th that the Funders Forum on Accountable Health held. And during that time, we heard from several initiatives who spoke to their current evaluations finding, as well as a panel who spoke on the value proposition of health-focused multi-sector collaboratives and or accountable communities of or for health. There was a lot of information that was shared. And later on, we will put a link to the recording, as well as this amazing brief that was prepared so that you can have that. Because I'm thinking some of you may not have been here. And it's my understanding that a synthesis is going to be available this next week. And during that time, there wasn't an opportunity, because there was so much information, for dialogue with participants. So today is really focused on hearing from communities and on their work and on the reflections, particularly about what value means to them. And so just a little bit about what we're doing. We're just going to do a brief breakout, right? We're going to go into check-ins because there's people who don't know each other, just to have an opportunity. We have a question for you. We're going to hear from Janet Heinrich from the Funders Forum on Accountable Health, and she's going to share a high-level summary. You're also then going to hear from 3 representatives from across the US on their work in their multi-sector collaboratives and or ACH. And then we will go into breakouts again to have you reflect and be in dialogue with each other, and then we're going to close. So with that, I am going to turn it over to Christina Olson.
All righty, everybody. Hello, good morning or good afternoon, depending on where you are today. As with most of our events through Phil, what we like to try to do is have an opportunity for everybody to just kind of get to know one another. So we're going to do a quick check-in, and we're going to do this in breakout groups. So we are going to randomly assign you to a room. We'd ask that you please try to be engaged. If you are able to turn on your webcam for those in your small group, that'd be awesome. There will be 2 to 3 people per room. And we'd like you to just discuss amongst yourself, first introduce yourself. So who are you? Kind of get to know one another. Where are you from? What are you doing? But also, what part of your job or work would you like to do more of? This is supposed to be a fun activity. This is nothing too pressured. Hopefully you don't feel that way. So we'll be breaking out into those groups in just a moment. Let me turn this on, and we will be in these rooms for 8 minutes. So you guys will have 8 minutes, and then we'll just come back here. So this is your opportunity to meet people. No pressure. Let us know if you need anything and just message us in the chat. All righty, I'm going to open those rooms now and you guys will be transferred. That's 2 to 3 people per room. Welcome back, everyone. I think we're slowly trickling in here, so thank you for your patience.
That was very fun. That was very fun. Did Janet come back?
I think we have a couple people still in their rooms closing out some exciting conversation. So thank you to everybody for taking the time to engage and be a little more interactive on Zoom. I know it's easy to log into a web discussion and think you're going to be a passive participant. So thank you for getting outside of your comfort zone here to really network, chat with others. We do appreciate that and hope it was fruitful for you. I'm going to turn it back to you, Sue, for
Great. Yeah, it was very fun talking about listening and the importance of listening and not having assumptions and needing to do more of that, and vortexes and galaxies. So very, very fun. So I'm now very excited to turn it over to Janet Heinrich with the Funders Forum on Accountable Health. And as I mentioned, this time that we have together today is really as a result of the conversation that happened on August 24th. And there were folks that, presented evaluation. Barb is with us today, Barb Masters, and she was part of a panel. And then I think we are going to put into the chat the link to the recording, as well as the link to the brief. And so that for those of you that didn't attend, you will be able to access that. So with that, Janet, I'd love to hear high-level summary.
Yes, were you going to put the slide up of the speakers?
Yeah, there we go.
Excellent. So thank you. This is really wonderful to be able to be a part of this discussion. On the webinar in August, we were fortunate to hear from the Innovation Center at CMS, the California Accountable Communities of Health Initiative, CACHI, the Build Health Initiative, and then the Washington State Healthcare Authority, which have the 9 regional ACHs. Our effort was to really look across all of these evaluations to see what we were learning. And it was fascinating over this relatively short period of time, 5 years, to see that organizations came together, putting forward a common table, asking different organizations to come and think through how they could better serve the communities and to be accountable to these communities. All of these initiatives talked about the importance of building trust, building their governance structure, but then moving to roles that were about integrating, working across sectors, moving towards innovation and redesign. There were some common issues that were difficult. Some people talked about these efforts being very messy work. Indeed, communities and the evaluations talked about the challenges of data gathering, analysis, and in particular, sharing data bidirectionally and with community-based organizations that are often lacking the infrastructure to have electronic systems in place. The other issue that people are working on is the financial sustainability. Many are looking at multiple funding streams, which is a challenge to manage. And it's difficult to find funding streams that will in fact focus on addressing those infrastructure needs and not only programmatic needs. And of course, that is an area that we plan to discuss further in the next webinar. I think it's important for us all to acknowledge that these accountable communities are not about saving money. In fact, in many instances, what people are finding is that more resources are needed in serving these under-resourced communities. But what is clear is that these organizations are moving from this common vision that they've worked on to develop to inclusion and recognizing community voices, to power sharing, and definitely equity and well-being in their communities. And this is such a positive movement. And it's really going to be interesting to see how communities move forward and engage in the future. Thank you very much, Sue.
You did. Thanks so much, Janet. I'm excited to get the synthesis. And I believe that we put into the chat the link to the recording as well as to the issue brief. So before we dive into this panel, I just want to give a shout out to all of you doing the work of supporting collaboratives. I think it can be very hard. It can be lonely and it can be isolating, and you're all truly like amazing, brave and courageous souls. So I just want to say thank you. I think the backbone organizational leads are required to be a bridge, talking to different systems as well as to community, all in service to change the way business is being done in your communities. And this foundation that is being built is built on trust, a shared language and ways to dialogue, all to this notion of getting value, but also impact, right? So some of the questions I think we're sitting with is, what is value, right? How do you decide what to buy or invest your time in? And what is the ACH health, the ACHs are a health-focused multi-sector collaborative like lead role in creating this foundation? And how do we change the way value is perceived and measured? So I'm excited now because I want to turn it over to 3 different representatives who are doing amazing work across the US. We're going to start with Gina Federico. She's a fairly new colleague and from Connecticut, and have enjoyed spending some time with her. She's the director of the North Hartford Triple Aim Collaborative. So in Connecticut, they have the health enhancement communities, right? So I think she's part of that effort as well. Then we're going to hear from Allison Polson, who I've known for a long time. And she's the executive director of Better Health Together, which is part of the Washington ACH effort in Spokane, Washington. And then we are going to hear from Annie Wu, who is a health planning specialist from East San Jose Peace Project, and she is part of the CACHI initiative. So with that, I am going to turn it over to Gina.
Great, thanks, Sue, and hello, everyone. Super excited to be here today and talk to you a little bit about the work that we're doing here in Hartford. I just, I'm excited to talk about value and centering community voice, We have been thinking a lot in our collaborative about these things. And I guess, you know, the one piece of context around this, as I kind of talked to you a little bit about the work we're doing, is that here in Connecticut, we have a fee for service model. So my colleagues that you'll be hearing kind of later in the presentations, I think one of the big kind of what I call like enabling conditions is, you know, how healthcare payment and reimbursement systems work in your location. And so for us, you know, we have been really focused on how to do this work kind of outside the formal healthcare financing system at this moment, because our SIM grant that we got created the AHCs, as Sue mentioned, which are health enhancement communities, to focus on upstream, but that has not been linked together or funded at the state level. So, who we are, though, is the North Hartford Triple Aim Collaborative. And what you see on the screen, which I am super proud of, is the revision of our vision, mission, and values that we just finished a couple of months ago with the help of national nonprofit Community Catalyst, and actually through funding that we got from Trinity Health and St. Francis Hospital, to really help bring our collaborative, which is mostly health-focused institutions, although we do have resident leadership, to really think about racial justice and how that work is aligned within or how we're living that value in everything that we do, including our mission, vision, values. So you'll see those in front of us, and you can see we've highlighted and intentionalized putting racial justice and equitable systems into our mission. And we can go to next slide. And so, you know, then you can talk a little bit about, you know, how we do our work. So like, what are our core functionalities, and then what is our overall impact? And we talk a lot about this, you know, in our collaborative, but also as we kind of think about the infrastructure building of the collaborative, which I think is a lot of folks on here are practitioners, right? There's like the work, the health improvement work, and then there's like the building of the collaborative. And so, you know, when we think about value, you know, I was kind of thinking about this today, kind of getting ready for this. And I think, you know, there's value to the community in the work that we're doing. And I think that, you know, we talk a lot about trust. And I think that is, you know, obviously absolutely important. But I'm starting to think about also, you know, this idea of rather than like trust, like I trust Sue and Sue trusts me, that like we trust this work as a brand. So like, do we believe that the work that the collaborative is doing is work that we believe like would have our good housekeeping seal of approval? Because I think the more I think about this, we really need to think about that, because, you know, we are constantly working on trust within membership and between members and community and members and other organizations. But I think we also need to think about like that brand equity question. And that sounds like super, I don't know, kind of capitalistic and kind of marketing-y, but I think it's true, because I think once you start this work, that so much of it is really around, you know, feeling like the community values the work and trusts the collaborative to be doing work that benefits them. So it's anyway, I've been thinking a lot about that, and I'd love to maybe have conversation about that later. So as you can see, we have core functionality that really kind of goes along with a more traditional backbone initiative, and then we can move to next slide. And you can see here our health improvement portfolio centers around healthy weight and child well-being. These line up with our state's health enhancement community priorities. You know, I think that you'll see underneath here, the work here is, well, I won't say predominantly, is funded through philanthropic funding. because like I said, we don't have like payment arrangements. So I think that's important to know. We have everything from like very local funding, like the local prevention council for Hartford, up to kind of what I would call kind of more of a system project, which would be the data across sectors for health, learning, and action, and policy and partnership, which is about, kind of working with our state Office of Health Strategy around connecting clinical and community data for health improvement at the local level. Next slide. And actually I would go down one more here. And so, the second piece of this, a couple of months ago, I was putting together this deck for our collaborative and thinking about, how do we demonstrate value and who are those audiences? And I thought that this, isn't going to be illustrative to the group around, what's happening locally in my community, but is important because it helps us think about how to follow investment. And I do think that this work, it's really important to understand that not oftentimes, but all times, that we really need to think about investment as very connected to the importance of the work we're trying to do. For example, we have a lot of conversations in our collaborative about centering community and voice and making sure that we are able to work with residents. But if that is not a funded part of our work, then it becomes very difficult to be able to resource that in a way that would be intentional and meaningful. And so I wanted to show this slide, as I did to our collaborative, to have people understand, of the funding we're getting in, which is, a couple million a year, although it's, I think, soon to be a little bit more, that we have that big piece of the pie that's really being invested back into community partners, folks we would call the ground game, working with residents, in every single piece of what we do. And it's by no means perfect, but I think it's one way to think about how we're making sure that the work that we're doing is impacting our audience, which is one of our audiences, and I would say the most important audience, which is the community that we're serving. And so next slide. And so this is just to give you an example of the types of groups that we bring together, the real sectoral nature of it. And so, we can see this is some work that we're doing with our city health department that's funded by the CDC around COVID. But you can see that we have like the city, obviously, Connecticut Children's, which is our children's hospital and the statewide network, the state. And then we also have like much smaller organizations like the Ministerial Health Fellowship in the Latino Way, which is a locally owned advertising agency. So we're always really thinking about, again, bringing in a variety of partners, but then also having them really intentionally working together to be able to do health improvement. And we talk a lot about this in our collaborative, and this gets to that question around key stakeholders, around the air game and the ground game. And we do feel like, when Sue was talking about our multiple audiences, and we're kind of the bridge, like this would be an example of that we really need to think about, what we're doing with our hospital systems and our FQHCs and state and city, but then also how we're connecting those organizations to the community-based folks serving organizations. And we also, again, an emergent thing we're thinking about with this, and sometimes this is one of those what I would call enduring tensions, is how are we building community capacity so that as we're trying to do this systems level improvement, that we're really scaffolding, I would say, our small community collaboratives and residents to be able to move into a space to be sitting with and having conversation with our larger institutional partners. So I'm going to pause there, and it sounds like we're going to hear from some of my colleagues.
Great.
Thanks so much.
Great, right on time. Thanks so much, Gina. Great. And I'm noticing in the chat, I encourage you, I think this notion of trustworthiness and that these multi-sector collaboratives are a trusted entity is certainly coming up in our research as well. So it's great to see this. Allison.
Hello, everyone. This is so much fun. I have said to Sue so many times, like, this is really lonely work. And while I have 8 colleagues from around the state, it is so just awesome to hear about work happening all over the country and how connected it is and how we're all sort of struggling through some of the same issues. So I'm just going to do a quick walk through of our work and how we have structured it. So we can go to the next slide. I love to note where we are in the space of Washington state, because I think part of what has made this super interesting work for us is just the overall dynamics of our region. So Spokane, the city of Spokane, is the 2nd largest city in the state of Washington. And we are surrounded by lots and lots of rural areas. So about 12,000 square miles, and probably in every other part of the state, there are more cows than there are, or part of the region, there are more cows and livestock than there are people. We have 3 tribal reservations, the Colville, Spokane, and Kalispell tribes, who play a really important role in our region overall. We can go to the next slide. We have 4 key goal areas that Better Health Together has been working on since our inception, which was about 9 years ago, with this mission to radically improve the health of the region. And the ACH work is really core to that. We also have a navigator program helping to connect people to health resources. And increasingly, we are seeing a much stronger link between that body of work and our ACH work. I will also just note that we are in the process of adopting a new strategic plan that has much stronger language around anti-racism, anti-oppression, and reducing health disparities. So we have been on a fascinating journey as both an ACH staff and board, and with our set of partners. So this promoting health equity for all by all really is dated conceptually for us, because right now we're talking about how do we shift power, how do we embed anti-racist practices into the community health system overall. We can go to the next slide. We have been thinking a lot about how we do this work. So this is a real consistent theme I think you'll see across ACHs everywhere, though we kind of thought we were unique in defining it this way. It's pretty fun now to be like, oh yes, so everybody thinks about their work in this way, but certainly the neutral convener has been an important part. And one of the things that I like to highlight is, while we are neutral, we have an agenda to radically improve the health of the community. And I think, that's a really important part of this. Oftentimes when we say neutral convener, I think that feels like you don't have an agenda, but we actually have the community agenda of creating health. So I know what we're trying to get at, and especially with funders talking about neutral, like we're not for any particular sector. But I do think it is worth talking about the strategy that we're trying to put in place that relates to how we get to, radically improved health. I would also note that, because we have an 1115 waiver that we're working under right now, we've had lots and lots of money. We are increasingly seeing that the policy work probably outpaces how much money we even have access to. And this ability to try and connect together what are unnatural partners sometimes to create policy agendas that allow us to come at legislators or at agencies with some different angles. I would also highlight that the leveraging data continues to be both a struggle and one of the areas that we think is just really, really critical. And this may be true everywhere, but turns out people are kind of weird about sharing their data and who has access to it and who can really help us get a full picture. So, I imagine we'll talk a little bit more about that from a capacity building standpoint, but as a independent nonprofit, folks feel weird about sharing information with us. And over our 5 or 6 year period, that has been a really significant struggle to get to what we imagine is this total cost of care, so that you could really look at how do you appropriately finance this work. In Washington, I think we're in a little bit of a both good state, bad state in folks feel like Medicaid should be used more generously to help support social determinant of health work. And yet there's not enough money in the Medicaid system to help shore up the vulnerabilities that exist in our housing and our food and our transportation and our education systems in general. So, how we pull those pieces together. And then the final thing that I just want to note for BHT that's really important is, while we're a regional collaborative, we have invested really significantly in each of our counties' ability to have a collaborative to really drive the work at the most local level possible. We can go to the next slide. And we can go to the next slide. I think that actually is a duplicate. I'll just quickly touch on our governance structure. So obviously we're a 501c3, our board governs all of our work. We have built out both this collaborative structure and this technical council structure to really invite anyone who wants to be involved to have a place to influence policy. And we're continuing to work on how do you, in a lot of ways, push that leadership and decision-making as local as possible. And yet, let's just say there might be a little ego playing out with the board of like, but in the end, we have fiscal responsibility, we have legal responsibility. So how do we balance that out? That I think is, an ongoing theme, probably many of us see. I will note though, our board has made an aggressive amount of decisions very quickly over the first 3 years of the Medicaid waiver. And all of those decisions were informed by either feedback from our collaboratives or from our technical council. So it's an interesting leadership dynamic, I think, in terms of how you're giving up control. And yet over the last 3 or 4 years, we have 100% given community the opportunity to influence that. Where I would say we've been weak is how we define community, and where there is a really significant shift for us right now to include more diverse, both organizations who contribute to community health and to community voice, which is probably a whole additional session. So I will rein myself in because I'd really like to go there and keep moving through our slides here. We can go to the next slide. This probably should have been a little earlier. I like to talk about us first before I talk about the whole state. Washington's divided into 9 accountable community of health regions. We all have some similarities and some uniqueness that is both based on community dynamics, how the ACH was originally formed. Some of them were formed within public health departments. So there is a public healthy feel more to them. Some of them were more focused on community-based organizations. Next slide. And then I just wanted to, as we think about what formed the ACHs, I think it's important to recognize that this came out of our state's 1115 waiver. And there were 5 components to the waiver, with the largest being transformation of the delivery system through accountable communities of health. And that within that, there was health system capacity building, integrating behavioral health, and then this very loosely defined community-based care coordination work. We clearly tried to boil the ocean, both to get the waiver and to get what ended up being $1.5 billion to be able to play around with this. And we're really finding that pacing is an important piece, and these underpinnings of equity, community voice, and capacity building being important overall. So I think I'll stop there and move on, let you move on to the next presenter, and look forward to the discussion.
Great. Thanks so much, Allison. I love the radicalness of what you're doing. And again, these slides are all going to be available for folks. So I'm excited now to have Annie Wu speak from the East San Jose Peace Partnership.
Hi, can everyone hear me? Okay, great. Hi, everyone. Thank you so much for having me here present to you. So my name is Annie Wu. I work at Santa Clara County Public Health. I coordinate the East San Jose Peace Partnership. You can probably go to the next slide. Yes, so a little bit about us. We are located in San Jose, California, which is in the Bay Area. As you see on the little map to the left, the star is where we are roughly are, and we are kind of nestled among all these tech giants, and definitely in the area of immense wealth and privilege. So there's some great irony there that there's such needs in our community. So PEACE stands for Prevention Efforts to Advance Community Equity. So we're a fairly grassroots organization, collaborative, made up of a lot of residents, CBOs, some business associations, and quite a few government entities, government organizations. We specifically work on 3 zip codes, collectively known as East San Jose. And our goal is to address conditions that lead to violence, and to really work toward preventing and reducing violence through a trauma-informed and healing-centered approach. And so we've been a Kachi site since 2016. And next slide. So just a little bit about East San Jose, or the 3 zip codes in East San Jose, Alum Rock, Mayfair, Santee. So as of 2018, we have roughly around 180 residents. The population is very diverse, made up of largely Latinx, Vietnamese, and other communities of color. Around half the residents are foreign born, and majority speak a language other than English in the home. So we have a lot of a legacy of racial and health inequities, seeing some of the things highlighted: high rates of violence, lack of housing, employment opportunities, and chronic disease. However, at the same time, we do have also a rich history of community activism and grassroots organizing, which provides that strong foundation for our ACH to build upon. Next slide. So just a little bit about our organizational structure. I think it's pretty standard, like a lot of the other ACHs. We have a leadership team that makes decisions governance decisions at a high level. We have a wellness fund that is community-driven, community-led. And then we have several work groups that works on addressing kind of some of the root causes of what we see are contributing to violence, such as displacement, lack of housing. We have a work group working on that. We used to have a work group working on gun safety, that since they kind of have split off from us. Another strategy we're advancing is really building up the linkage between clinics to community with regard to kind of screening and educating and referring people who experience domestic violence at that primary care level. Also, another strategy we're working on is the building capacity in our local promotoras or community health workers to be able to address domestic violence, intimate partner violence at that community neighborhood level. So all this to say, and then public health is a backbone for that. And all this to say is that we have been trying and for the most part succeeding to have community stakeholders serving as in leadership positions as co-chairs at all levels of these structures in the work group, as well as on the overseeing the wellness fund and overseeing taking part in the leadership team decision making. And by community, when I say community, I do mean so people who have lived experience of living in East San Jose, who are residents of East San Jose, and also grassroots organizations, staff who work directly in the community with residents. Next slide. So what is Peace's value add? So this picture kind of speaks to me because I feel like, unlike some of the other, I think ACHs in other regions, I feel like in East San Jose, in Santa Clara County, we have kind of an abundance of just community activism, collective action. You know, there's just a plethora of neighborhood associations, resident groups, coalitions, collaboratives, you know, led by many different organizations. And we're all kind of these, I don't know if you call it constellations or galaxies or systems that are just orbiting in and out of each other's orbits. And we're all striving for, you know, the limited resource and time to work on this or that issue, especially in the context of COVID, right? Everybody is trying to work together to address COVID. So in this environment, sometimes it is hard to figure out what is the value add that Peace can bring. Certainly we are not the biggest collaborative or, you know, the most important. And what can we say to our community partners to get them to give us, you know, a little bit of valuable time to join yet another collaborative, right? So I have some thoughts to share. Go to the next slide. Yes, so as I think Allison mentioned before, really having that neutral space for collaboration is definitely one of our key values. And I love what Allison said about neutral, but having an agenda, for sure. So for us, especially as a government entity, I feel like Peace has really, through the CACHI model, right, has really created that space that allows government entities to work with community leaders, community partners in a non-traditional way, in a way that's different from how typically how government works with communities and how community work with governments. That a space we like to think of as a safer space that serves as an incubator for more creative, innovative, collaborative efforts that goes outside of these, like I said, traditional, typical ways that we tend to work with each other. What this means for us is it's a space where we can really, quote unquote, practice or learn some of the key concepts of CACHI, right? So aligning activities, building mutually reinforcing strategies, developing a culture of collaboration, not competition, practicing distributed leadership. And what does that really mean? You know, when like everyone's a leader and nobody's a leader. And really building equity and resident leadership into every aspect of Peace, which for us means, you know, a lot of times we feel like that's kind of, people say that or people put that on their charters, but how do you actually operationalize that, right? Next slide. So I think another value add that we bring is this vortex, which I just found on the internet, but it's really speaks to how we see what our work is trust, right? When we started 4 or 5 years ago, you don't go in with like, okay, we're gonna first build trust and then we can do all these things. But, you know, of course we start off with like, we have this massive work plan, we're gonna do system level change, we're gonna have all these amazing indicators, outcomes achieved by year 1, year 2. And then we, of course, as usually you realize you spend years and years kind of having conversations, taking one step forward, 2 steps back, negotiating things like doing activities that are maybe reciprocal in nature or just providing mutual aids to each other. And through this process, you really realize that we have really built trust within our community, within our partners, that allows us to build a foundation for kind of more impactful and more deeper action, right, when the time comes. And that really that kind of relationship building work at the beginning allows to then create kind of a shared vision, shared mindset, cultural change, attitude change. And really, even today, like a lot of majority of the work that we're doing, the quote unquote achievements or accomplishments that we made are, when you think about it, it's more internal, process oriented, may seem incremental, but again, it really kind of builds that foundation for that deeper alignment. Next. Great, thank you. And so some of the examples, you know, of what we were able to achieve in past years. So in 2020, April 2020, you know, in the midst of COVID, you know, we paused our work and then a lot of our community leaders came to us to say, even though we're not meeting to talk about high-level system change, but our communities are really suffering. And so very short amount of time, we were able to raise over $600,000 through a lot of the philanthropic relationships that our partners have. And we were able to support over 730 East San Jose individuals and families and over 30 small businesses. Another project that we did was working with our partners to figure out how to co-design and collaborate in submitting a proposal together, right, to get money to fund a capacity building project for our promotoras. And even though that was a bit of a rocky road, in the end, we were able to secure over $100,000 in funding for this project. And then finally, we participate with our partners in a lot of different advocacy campaigns. Some of them actually kind of fall outside of our traditional portfolio intervention, but still, if it's something that community has identified as a need, we kind of join in the effort and achieve some wins in that process. Next slide. So I really, at this time, I wanted to talk a little bit more about something that's really key to our ACH. A key principle that we return again and again is our desire for our ACH to be community-driven and resident-led, to really center and uplift resident voice. And what I'm talking about here is, I'm sure many of you are familiar with the latter, participation or co-design. It's been called, I think, different things, but really kind of moving from this informing, consulting, engaging, like the middle piece, to the co-design, co-producing, and really figuring out how does that work, right? How to make it happen. So those are questions that we really wrestled with. So one thing we learned in building kind of resident leadership is that it's really not a one-step process. It's really not just about recruiting X number of residents to sit at various tables or governing bodies, and then you are good to go. But however, it's an ongoing process that takes a lot of investment, time, and energy. It starts with building the right relationship with the CBOs in your community that actually work with residents, for a much longer time. It really starts from a long, kind of a long-term investment. Sue, I don't know how much time I have. Did I run out of time?
If you could, you've got about a minute.
Okay.
So, yeah.
Okay, so I'll just keep going really quickly. Next slide. So just some of the questions that we have been wrestling with, questions and tensions, like I like to call. So how do you balance your agenda, which is high-level system change, or some of these very high-level issues with residents' needs and residents' agenda? How to ensure that residents understand the frameworks, concepts, and issues, or the very high, kind of very technical elements of the work you're trying to do, for them to effectively participate in your work, but not to bog them down or overwhelm them with too much information. Should you include a resident at every table, at every decision-making space, or do you create spaces that are tailor-made for them and try to filter or channel their input into other decision-making spaces? How do you balance the desire to include, again, residents in every decision-making process, but respecting that they have very limited time, they have maybe different interests and different capacities? And then finally, when do you invite residents into the design process, right? And how much internal work do you do before you open the doors? Next slide. So finally, some of the learnings, and I like to call experimentations, is for us, we really felt like we needed to take a step back in a lot of our tables, in a lot of our work groups, to take a step back and figure things out for ourselves before we actively reach out to the community and engage them. That could mean really figuring out how public health can work better with community CBOs, or how CBOs can work better with each other. Another really important piece that I learned for myself is the importance of listening. Before you ask people questions or ask them to contribute to your agenda, to really sometimes that means going into the community, going to spaces where residents or people with lived experience already work, right? And learn about their work and listen to what they're working on, what their needs are. Creating space in every meeting that you have residents attend for them to share, whatever they want to share about. And the importance of working with those who already work with residents, right? Working with CBOs and community workers, frontline service agencies that already have that experience. And yeah, I think I'll stop there.
Great, thank you. Incredible. I heard a lot of similar words, right? Just things. I think this neutrality, the trust piece. I think Annie, you brought up co-design, which I think is pretty incredible. I'm very struck by the learning and the reflection that's happening. And the galaxy and the vortex, I think is amazing. We are going to go into breakouts. I think you just heard a lot of really great information. I think we have time for, if people want to put anything into the chat, maybe like to hear from just like one person. I think we want to, the tension we're balancing now is we want to make sure you have as much time as possible to be in dialogue. So any questions that anybody wants to ask or put into the chat? Okay, it's a lot. Density silence, that's a term. Rick, did you have something you wanted to say?
Yes. Well, first of all, thanks to all three presenters. That was really, really great to hear about 3 multi-sector collaboratives with definitely some differences and some similar themes. And I really appreciate the emphasis on like meaningful roles for residents and community organizations in the work. And that to me stood out. In sort of a different direction, when I was thinking about this, as well as the first, the Funders Forum, when I think about value, money comes to mind. And I just wondered, like in Connecticut, for example, the actuarial analysis of this Health Enhancement Communities Initiative says that in 10 years, Medicare would save, I forget, $3 billion, in avoided healthcare costs, and Medicaid would save $2 billion in avoided costs, related to interventions that would happen at a regional level across the state. So that I'm just wondering, like, that promise I think has been made, or that opportunity has been identified in all of the states, and I'm just wondering if anyone has any experience of trying to operationalize that that value proposition. Is it is it actually driving actions at the ACH level to generate those savings and capture a portion of those savings and reinvest those savings back into the community? That's what's on my mind. I don't know if you want to cover it or go to breakouts.
I think it's a great question, and I think we can kind of sit with that and come back. But I appreciate you, Rick, putting that out there. I think we do want to have people get into dialogue with each other. So these are going to be random breakouts. And Christina?
Yes, I am setting those up real quick. So we will be jumping into random breakouts. As with the last breakout session, if you guys are willing, it'd be great to show your camera so that way people kind of are able to introduce themselves, know who each other are. If you are unable to participate, totally understand, that's fine as well. But we're going to just be discussing a few things. So feel free to discuss kind of what Rick has brought up, your own personal reflections, but what does value mean to you? How is your collaborative demonstrating value? What kinds of tools, resources, or external supports does your collaborative need to effectively demonstrate value? So feel free to be creative, kind of go wherever this leads you. We will be breaking out into those rooms now, and you guys should get a request and permission on your end to enter that room. Thank you so much. Hello, everybody. We are waiting for people to trickle back in.
So Allison, I heard you were on jury duty and convicted. So what a week you've had.
It was a lot, I'm not gonna lie. I take a long walk, have a big glass of wine last night, and I slept well.
Yeah, that's awesome. That's awesome. Great. Okay, so we just wanted to spend a couple of minutes. Hi, Andrew. Just spend a couple of minutes hearing from you all just about your discussions. And I did want to circle back before we close this piece, Rick, and make sure I'm clear because I see some interest, right? I know Barb, you asked a question, and Allison, just in terms of, is there actually a study out there that's speaking to that? So I'd love to hear from your discussions and just what you talked about and any main reflections that came up.
I'll just put a link to a press release about the study. It was part of the health enhancement community's work in Connecticut.
Okay.
This release will not give you much detail, but it cites the study that was done by Health Management Associates and Aram Actuarial Consultants. It only talks about one of the studies, not just the Medicare one, not the Medicaid one. But anyway, for what it's worth, I'll put it in there. I have lots of graphs and charts and so forth in the study, but it wasn't a publicly released study.
I see. Okay.
But it was considered by the state in terms of what they might discuss with payers in terms of the value of the Health Enhancement Communities Initiative.
Yeah, great. Thank you. Okay, so let's hear from some folks in terms of your discussion.
This is Angela. Can you all hear me?
Yeah, yeah.
Okay, so one of the things we talked about, and I shared in Hartford, Connecticut, our North Hartford Triple Aim Collaborative was formed prior to COVID. And I believe the value add was that the relationships had already been formed that actually helped us respond to COVID in a much more productive and effective way. And it was a really good model. Various institutions and community-based organizations and residents could actually come together and solve a really critical problem. But it was really anchored on the relationships that had already been built. So we knew, to be able to place a phone call instead of, now having to be introduced to whoever the person is at an X hospital, can you come out and do testing? Well, all of that was, those relationships were already in place, and it made it a lot smoother process. And actually, I don't think I would be lying to say that it could have definitely has saved lives in the process of being able to respond so quickly.
That's awesome. So that trust piece, relationship building. Yeah. Other thoughts, Barb? I'd love to hear from you.
Sure. So I was actually in the same group with Angela.
Oh, you were? Okay.
And with Allison. And we did talk a little bit about who pays for that. That, and I think as Angela was saying, that they were able to respond to COVID so much better because they had these relationships in place through work that pre-existed COVID, which was certainly the experience of many of the CACHI communities. And I raised the point of, and that but how do you get people to pay for that? Because it's not direct intervention, programmatic work, and yet the payoff for that investment in relationship and trust building can be seen in all kinds of ways. And Allison noted that she believes that that just has to be a government role. If you're going to be a neutral convener, and it's not that expensive, I mean, what you're paying for is a little bit of, you know, infrastructure money, so that you can play a neutral convener. And if you're funded by somebody, it starts questioning, you know, the neutral role that you play in your ability to have an agenda that's on behalf of the community and not on behalf of any one person. So, you know, so I think there may be a way to start thinking about, well, there's just, that is a role that government pays for, and it could be state or federal. And the work of the ACH then is funded by, you know, specific programs, specific government payers, or by philanthropy. But there needs to be just an acknowledgement. And I think that is all of our task collectively, is to make this value case for being that convener that brings people together, that builds trust and relationship, and that should be paid for. I mean, that's our struggle in CATSI.
There you go, done.
There,
That's right. Yeah, well, that's awesome.
Allison, I don't know if I captured you accurately. I always hate to report on what somebody else says, but that was my
I think you did. And I just want to note, I do come from a red part of Washington State where government is rarely the answer. So that puts me a little out of step with some of my partners, but I do think it is, it's an interesting way for us to think about infrastructure for communities in general. Maybe Joe Biden's been calling me. I'm not sure.
He probably has. Yeah. Very good. Oh gosh, it's 11:30. We're boy, the time just goes. But any last comments? Gina, Allison, I think Annie had to drop off, but I'm so grateful for your time and for sharing your work. So thank you. I appreciate it. And we have an upcoming session that I think Christina has put into the chat, and there is a tool that's called Lumio, and it's a tool that multi-sector collaboratives can use for kind of transparent decision making. So we're going to be hosting a session on how folks can use that. And then we are hosting a session at APHA. It's a pre-conference learning institute. So if you're interested in that, there is a link there as well. And so with that, thank you. Thanks for your time.